Hello. Um, Here we go. Trying to start with talking about pain in labor today and fetal assessment during labor, both of which are incredibly important when you're taking care of the laboring patient. So, um, all of these objectives talk about the discomfort, non-pharmacologic, pharmacologic pain methods. And then also here we are going to be talking about fetal assessment and fetal well-being. And we always need to remember, of course, that we have two patients when we are laboring a patient. So we have to always assess how the baby is doing. And so that's why we have fetal monitoring in the first place. So, okay. So you guys know about pain, visceral, referred, somatic. So visceral, you would be the pain that comes from the nerves in the uterus and the cervix. Okay, as that uterus is stretching and pulling. In labor, we see referred pain as pain that radiates from the uterus to the abdominal wall, the lower back, the thighs, the gluteal area. And especially with what position of the baby's head. How about occiput posterior? Remember that occiput posterior puts pain back on the sacrum and gives mom a real nasty backache. And then the somatic pain is the skin and deep tissue. There's intense burning as it stretches. Sometimes it tears. Obviously, that is uncomfortable also. The pain in labor is intense, it's persistent, and very difficult to cope. So we know that the pain is finite, but when women are in the middle of labor, it just seems contractions are coming one after the other. They're getting closer together, they're getting stronger, and increased pain. And so if we're not there to help them through that pain experience, they will have a much less happy time having their baby. So the perception of pain, everybody knows that labor hurts. And when you are afraid about pain, you can actually, through the tightening of your muscles, through not breathing deeply, can actually increase that perception of pain for moms. A lot of times, if a mother is not educated, knowing about the labor process, knowing some things that she can do during labor to decrease the discomfort or the perception of pain, everything is just much harder. She's very afraid. She tenses up. If you're very tense, it takes longer for your uterus to work and your cervix to dilate and efface. And it just kind of is this cycle that just goes around and around. And anxiety really feeds into that pain perception. Expression of pain, we do see a little bit of blood pressure and heart rate increasing, but not as much as you think. Hyperventilation, we see a lot. What would you do? Think about what would you do if the patient is hyperventilating during labor. What would you do? You would have them breathe into their hands, give them a paper bag to breathe in, and then nausea and vomiting are part of this, especially during transition. When we hear moms, they groan, they're crying, they moan, and all of that increases anxiety. Okay, so factors that influence the pain response, physiologic. We have that long labor, mom is fatigued, there's very intense contractions, and so those are the physiologic factors. Culture, you need to read the box on page 383. Be sure you read that. Read the box on culture on page 383. But different cultures have different uh, traditional ways of coping, and it's very interesting. Anxiety, remember that cycle of pain, the fear, the muscle tension, the decrease in the O2, and the increase in the pain. A previous experience can hurt too. If mom had a bad experience, difficult labor and delivery, the anxiety would be increased. Um, the as is no previous experience also, in fear of the unknown is not good either. Um, the gate control theory of pain, you guys remember that? It's kind of that whole trying to um, trying to reassign that the them um, from even concentrating on that intense pain by massaging, doing effleurage, having distractions like breathing exercises, music, darkened room, some of those kinds of things. Some women use hypnosis. Okay, comfort, it's a natural process, and there are lots of different things that we can do to keep moms comfortable. Support is really important. The saddest thing you can see is a woman who is all by herself and laboring alone. Really important to have support from caregivers, and then having a continuous presence with that patient is really important. Definitely increases satisfaction. One person to concentrate on, one person who knows you. It's important. And then having a great environment. It's important to give mom choices about how she wants that birth to be. Does she want people present? What does the physical space look like? Does she want to deliver in the water? Does she want to have skin to skin right away before they even wipe the baby off? So giving moms choices helps her have control. It also is showing more respect for her too. So, okay, non-pharmacologic methods of pain. There is a box 17-2, page 385, that you must read. You need to know that. Childbirth preparation methods, the old one that we really has been around for a while is Lamaze. It's kind of based on, it's psychoprophylaxis. It's very structured breathing methods during the different stages and phases of labor. The Bradley method is husband coached. And there are childbirth educators everywhere. Most of them are not necessarily, they have information about Lamaze, but they're not necessarily Lamaze certified. And they kind of mix and match and teach a variety of different methods within their childbirth classes. So people go to childbirth preparation classes, usually starting at the beginning of their third trimester, middle of the third trimester. Okay. They start to think about what's going to happen during labor. So the most important things really are the relaxation, breathing techniques. Those are pivotal. Besides keeping mom well oxygenated, they do provide distraction. And some of the things that we also do are some guided imagery. Having them practice is very important. Deep breaths need to come from the abdomen. And the more you can relax, the faster and easier it is to actually dilate. So it works really nicely. And when a mom has an idea of what's going to be happening, it increases her confidence in her ability to labor without meds. That being said, most women now don't labor without meds, or they almost always, usually, I don't know the percentages, but it's high. Most moms end up having an epidural, which is fine. They're much more comfortable. It's not always the easiest thing. We'll talk about it in a few minutes. But it is a way to be much more comfortable during labor. There's also one more thing I need you to read here. It's about paced breathing, depending on the stage. Let's see. If you read page 387, box 17-3, that would be a good idea for you also. Okay. All right. So, effleurage and counter pressure. Effleurage is not really massage. It's like a light stroking, just relaxing, sometimes on the upper thigh, sometimes on the uterus during a contraction. Sometimes mom thinks that that's going to be an okay thing, and then she doesn't really like it when she's in labor. But touch from the partner is a good thing. It's good for moms to really decide on non-pharmacologic methods before labor. Aromatherapy is one that you can do. Head, feet, hand massages. They want to be nice and gentle. Also, holding hands is important to let mom know as she's going through those contractions that somebody's there with her. Therapeutic touch is like kind of a certified thing. People get certified in it. It's energy fields, and practitioners really try to increase relaxation and decrease anxiety. I've never seen it done in labor. I've seen it done with other patients, but not in labor. And then application of heat and cold. We want warm blankets, a warm bath. All of those things are going to really help increase blood flow, help mom relax. Once mom hits transition, though, she's going to be very warm. She'll probably throw off all bedclothes and work on breathing. And so cold cloths there really feel more comfortable for her. A lot of times moms will want a fan on during labor because they get very hot. Some other things that we see sometimes, acupressure and acupuncture. You can do that. Acupressure is continuous pressure on the neck, shoulders, sacrum, hips, ankles, toenails even. And let's see, TENS units, transcutaneous electrical nerve stimulation. Basically, you can actually buy these at Target now. It's electrical impulses that can interfere or that kind of stimulate. It really works toward that gate theory of pain relief. And so it can interfere with the fetal monitor, especially if you have an internal fetal monitor on. So sometimes it doesn't work as well. Water therapy is very, very popular. We have different ways. Oh, and by the way, this is a TENS unit right here. But we have different ways of doing water therapy. Soaking in the tub, and you can see we have fetal monitors that actually we can monitor mom while she's in the whirlpool bath, and then spraying water on the belly, spraying water on the back while she sits and labors. Oftentimes water is a huge thing for comfort of mom. An intradermal water block, they used to put, I've seen this done before, they used to take sterile water and 4 points in the lower back, and they would inject it. It's like an little intradermal injection, and I'm not sure if it puts pressure on the nerves or what, but it kind of stings when they put them in, but evidently it helps back pain, and I've seen it done. But that was a long time ago. I've never seen it done here. Aromatherapy, again, choose before. Mom should know what she wants before labor. Music is distraction again. Hypnosis. Hypnosis is something that that has been used and quite effectively, I have to say. It was very big in the early 60s and mid 60s. And my dad was an anesthetist, and he hypnotized my mother through all of her pregnancies. And you have to practice it a lot. It's not something that you can just pick up and do the day of delivery, but it's kind of putting yourself, a woman can actually put herself in a hypnotic state. It's deep relaxation, focused concentration. And my mom didn't have any pain medications in all 6 of her labors. And she actually gave birth at a time where they gave a lot of really strong pain meds. So it really worked for her. I've met other women who have done it also. My dad once hypnotized one of my mom's friends, and then he was on the phone long distance with her while she was delivering her last child. So biofeedback is it's kind of like hypnosis. It's a formal process. Again, the thought is that you're using thought to control the body. You practice it with a machine, and it's a practice response to pain. It, again, takes a lot of commitment to with the hypnosis and the biofeedback to get to a point where it's actually going to work for you during labor. Okay, so pharmacologic pain management. And did I say counter pressure? Now I'm wondering if I talked about counter pressure. I think it was over here. Counter pressure, you can use your fist, or actually the flat part of your fist, or a tennis ball. And while mom is having a contraction, actually be pushing against the lower back where if baby's OP and mom is having a lot of back pain during labor, if the partner or the nurse actually pushes against the back while she's having a contraction, it will help take some of the pressure off of mom and be a little more comfortable. So just wanted to get that in. Okay, pharmacologic pain management. We give sedatives sometimes. Usually sedatives are given to relieve anxiety, induce sleep. Sometimes women have a prolonged latent phase. Now think about what is the latent phase. First stage of labor, the latent phase is that early phase. And sometimes women have a time where they have regular contractions. It's not necessarily doing a whole lot except softening things up. And so when you hear that women were in labor for 4 days, this is what they're talking about. They're very uncomfortable and they get really, really tired also. So sometimes we would give a sedative so she can get a good night's sleep. Sometimes she'll wake up and she'll be in good labor and she will have gotten some rest. So, but theoretically, this will lessen the intensity of the contractions and help promote some sleep. Barbiturates, Seconal was a really big one that we used to give in the olden days, a sleeping pill. Phenothiazines, Phenergan or Reglan, something that will decrease nausea and vomiting, but also that secondary side effect is making you sleepy. So that's a good one. We can give a benzodiazepine, would be Valium or Ativan. But we have found that in moms who have taken these drugs, it's very hard afterwards for the newborn to get their own thermoregulation going. So we may have problems with the baby afterwards, so we don't generally give those, the bennies. Okay, let's see. All right, so anesthesia. Okay, anesthesia is everything that we would give. So the analgesia the sedatives, the analgesia, amnesia, relaxation, All of these things are under anesthesia. So the first is analgesia, and obviously we're going to be giving this drug, but it's totally going to depend upon the stage of labor that the woman is in, how she's coping, what her birth plan is, and how the baby is looking before we actually decide what we're going to give. Okay, so our systemic analgesia are opiates. So the opiate narcotic agonist analgesics would be like fentanyl, which is very short acting, so sometimes we'll give a little of it, but Demerol, we used to give that. That's an old drug. It has a lot of side effects. We really don't use it much anymore, and it's kind of, it would last a long time. We'd see prolonged respiratory depression in the baby, so we don't do that. The opioid narcotic agonist antagonist analgesics, so Stadol, Nubain, we see less respiratory depression, and this isn't going to knock them out either. We used to call Nubain joy juice when I first started working in labor and delivery, because women were still having hard contractions, but they just didn't care so much anymore about it. So also we would see less respiratory depression. It doesn't hang on as long, has a shorter half-life. If we do have some respiratory depression in the baby, we would give a narcotic antagonist, which would be Narcan. Okay? All right. Okay. So nerve block, analgesia, and anesthesia. Some of the different nerve blocks that we'll do, if they're going to cut an episiotomy, or if there's been a tear that they need to stitch up, they will actually put lidocaine in the perineal area that they're going to do the stitches, which is very easy for you guys to understand. If you look at the picture figure 17-9 on page 396, it shows a pudendal nerve block. A pudendal actually we used to call it a saddle block. They go in through the vagina, and they have kind of a horn thing, and I'll be showing you guys this when we get back together again. And they will feel for the nerves that run near the ischial spine, and they will actually inject those. And about 10 to 20 minutes before the birth, it will numb up that area so they don't have as much of a ring of fire when the baby is crowning. It can decrease their feeling of that bearing down feeling too, so it can have a side effect. And where I came from, 30 years ago, we used to do a lot of pudendal nerve blocks. They were almost like what everybody had. But now things with epidurals, now we, don't really see that nearly as much anymore. So spinal anesthesia, that is total numbness. You can't do anything basically from the nipples down, maybe a little lower than that. And we use that for C-sections. And that's definitely a C-section kind of a thing. One of the side effects of this are the post-dural puncture headaches. We call them spinal headaches. And severe headaches when they're sitting up. And basically it's because they get an anesthetic when they're going into the spinal cord, they puncture the dura. And so you get some of the anesthetic in the cerebrospinal fluid. So what they do then, if that is the case, they will do an epidural blood patch. An epidural blood patch, there's a picture of it on page 399, figure 17-12. They'll take 20 mils of blood out of mom, and then they inject that into the lumbar space, into the epidural space, they will clot. The blood will clot and it will patch it up so you don't have any leaking going on that's causing that headache. Moms usually feel immediate relief from that, and you want them to not strain or cough for at least one day. And then we're not going to be giving her any aspirin or NSAIDs because we don't want to dissolve that clot. But we don't see this as much anymore. They have different ways of doing the spinal blocks. So, they used to have to lie flat for 8 hours after they had a spinal, and it's not really like that anymore. A little more short acting. So that's a little bit better. Okay. Nerve block analgesia and anesthesia. Epidural anesthesia or analgesia. It is very effective. What we do is we insert a needle into the epidural space, and it's the one that's right before the spinal space, and they will run a little tiny catheter in that space, run it down, and then we hook it up to medication, and we're constantly giving meds into the spinal, into that epidural space. And it makes mom numb in that uterine area. Usually the legs are feeling pretty heavy, but mom can usually still move her legs a little bit depending upon how strong it is. So, all right. So we do see these a lot. There's, I have a picture of what it looks like. Sometimes the physician will have mom laying on her side. She has to curl up so that it opens up that little space in between the vertebrae. Or she can be sitting up. Now, unfortunately, mom still has contractions while she is having this done. So that part of the epidural can be very, very uncomfortable. It's really no fun. But then afterwards, everything is taped up really well, and then we will hook it up to a pump and run a constant, continuous epidural lock in there. And usually it's pretty effective. Sometimes you can have the epidural work on one side and not the other, or there can be like just a hot spot that doesn't get covered. So we have to be really careful when we have a patient with an epidural that we are continuously moving her from side to side, because mom still needs to move during labor. That's one of the things that we see. It kind of slows down labor because mom isn't moving. But yeah, we use opioids. Let's see. And oftentimes when mom gets to the stage where it's time to push, she's complete, we will just turn off the continuous medication and actually wait until she can feel that urge to push. Because it's numb, she may not feel that Ferguson's reflex and have a strong urge to push. So usually we call it laboring down. We'll usually let the contractions just push the baby down, and then once she starts really feeling the urge to push, then we let her push. Otherwise, she's pushing, she's not really sure where she's supposed to be pushing because she can't feel it, and all it really does is wears her out, and that's not good. So let's see. She's not going to be able to walk on it. Her legs would kind of give out under her until that epidural is worn off. The nice thing about it is that it does wear off really quickly. One of the things that we see right after an epidural has started, or right after we've inserted it, is maternal hypotension. It's really common. All of a sudden, we take blood pressures like every minute when we're doing this. but all of a sudden mom's blood pressure drops. We notice a lot of times we notice it because the baby's heart rate drops and we'll have a prolonged deceleration. And so we have to have the antidote ready, ephedrine, which will help bring mom's blood pressure up right away. There's an emergency box on $3.99 that you also need to read. Okay, so sorry about that. When your boss calls, you have to answer the phone. Um, so the epidural anesthesia, again, know that emergency box on $3.99, and you need to know that maternal hypotension is a common problem with ephedrine. And when mom has hypotension, baby's heart rate will react by going down, and it will stay down for a while. We have to give ephedrine IV to bring mom's blood pressure back up. So it's kind of an emergent situation, but it's pretty common also. And so because it's a common thing, we make sure that moms have a lot of fluid on board to support that blood pressure before we even start the epidural, before we start to put it in. So intrathecal, an intrathecal is something that they use for C-sections. It's just like an injection, and it helps for pain. They can, they're not dead or anything, but the pain in their incision is lessened with that. So here is, okay, we saw these, right? Remember, we put those on a continuous pump for the epidurals. So some complications. If mom has an active or anticipated serious maternal hemorrhage, so if she's going to, like has low platelets or has a clotting disorder, and we're really worried about a hemorrhage, obviously we're not going to be able to maintain her blood pressure, so we wouldn't do that kind of a block. If mom has hypotension anyway, we're going to watch that. Maternal coagulopathy, obviously she needs to be able to clot. Let's see. If there's a decrease in platelet count, we're not going to be doing that. And then the rest of them, obviously, we're not going to do. The inability to cooperate for some women, if they're really strongly in labor, you have to sit still. It's very delicate. That epidural space is way harder to find and way slimmer than the spinal space. And so it can be an issue. Doctors like it when moms get epidural blocks because they are calmer during labor and the delivery. But moms have to sit still. So the timing of epidurals are really pretty kind of delicate. If you start give an epidural too soon, it can stop labor or really slow it down. I mean, an epidural will slow down the whole labor process anyway. But if you wait till too late, mom can't hold still. And so you got to get that. Probably early active labor is when you want to get started with that. So, okay. And this is just a picture of the blood patch, where you can see on B, they're actually injecting the blood there. And then this is the epidural space. So they're going in through the skin, in between the vertebrae. Here's the epidural space, and then this is the spinal space. So they have to stop at the epidural space, and they actually put a nice little clot there to stop the bleeding, so for the spinal headache. Okay. And there's a box that you probably want to review, box 17-6 on page 407, that just talks about nursing care. It's just a quick one. Okay, so something that they used to do in the 50s was called gas and air. They used nitrous oxide. Nitrous oxide would be the same thing as laughing gas that they give you at the dentist, if you've ever had that. And they used it in the 1950s, more in Britain than in the United States, but they did use it in the United States. They are also, it is starting to become more popular once again. They are using it for children's procedures. It's basically patient-controlled analgesia. So the mom, when she's getting a contraction, she would breathe in a mixture of, 50% nitrous oxide and oxygen together, and it would put her in a euphoric state. Okay, so she's a little less in pain, and then it can cause some nausea and vomiting. Dizzy, drowsiness, but that's, mom will tend to be more comfortable with that. There's really not a big downside to that. And then there's this little thing that says gas and air. It's just a nice little explanation from Call the Midwife, one of my favorite shows, about what they did in the 1950s. So it's a fun little thing to watch. It doesn't last very long. And then general anesthesia. General anesthesia is not something that we use. When I first started practicing, they didn't do spinals for C-section, so moms weren't awake. And we had to, as soon as the anesthesiologist said go, they, as they're pushing in the anesthetic, they would cut, and they had 5 minutes to get the baby out, because if the anesthesia hit the baby, obviously we would have to intubate the baby. The baby wouldn't be able to breathe. So we wouldn't want that. So we were pretty quick about getting those babies out. The labor nurse had to help with cricoid pressure and to help with the intubation. So now we would only do it in an emergent situation. Probably only about 10% of C-sections now are with general anesthesia. We have to get that baby out fast. So care management for non-pharmacologic interventions. There's a nursing care plan on page 405 that you can look at. But the job of the nurse is to support and educate the couple on the techniques, helping them use them. Obviously, ideally is taking childbirth classes beforehand and practicing some of the breathing techniques. But that doesn't mean that the nurse cannot coach the mom and to help her support a non-medicated birth. And we've had a couple lately where women have come in, or we just had an induction last week where it was a Primip, and she went very quickly and didn't have time for pain medication. And so it's really important for the labor nurse to be supporting mom. And we'll talk about that more for Tuesday's class. But let's see. Care management for pharmacologic interventions. Obviously, anesthesia consent. That timing of administration is, again, really critical. If we're giving an IV medication, and that's what we usually give, we will, when we're and you want to circle this is very important. When you're timing the administration, we're talking about how during the contractions, remember, all the blood is pushed out of the uterus. So when we're giving pain medication, we're going to give it, obviously, during a contraction. So we'll start pushing it and slowly push it in during the contraction. And what does that do? That decreases the fetal exposure to the medication, because if mom would go quickly, the baby could be affected by that medication and they won't take their big, huge breath. So that's the other part about timing of medical administration. Just like with an epidural, if mom gets to, transition or 7 centimeters, we can't guarantee that the drug, if we give the drug then, that it will wear off. So we cannot give mom that IV pain medication if she is just about ready to deliver. So that's another thing for timing. And it's pretty sad if somebody comes in and they're 7 centimeters and they're really uncomfortable and they want something for pain and we have to say, I'm sorry, it's too late. It can be very frustrating for them, but the baby has to come first. Okay, so timing we think of timing in the manner of timing not too late in the phase of labor of stage 1, and then also timing of administration is giving it during a contraction to decrease fetal exposure. Okay, we use IV mostly for the IV route. It's rapid, it works right away. Obviously shorter acting. Intramuscular route is less common. Obviously, it lasts too long. It stays in the body too long. It takes too long to work. We would give an IM injection, sometimes of morphine, if mom had that latent, the latent phase of labor, if she was having a really long latent phase and she was too uncomfortable and couldn't rest. Sometimes we would give some morphine IM, and it would last a while to help them sleep. But it's pretty not common. Okay, question. A woman in labor has just received an epidural block. The most important nursing intervention is to A, limit parenteral fluids, B, monitor the fetus for possible tachycardia, C, monitor maternal blood pressure for possible hypotension, D, monitor maternal pulse for possible bradycardia. And the answer is C. Okay, and remember that when mom's blood pressure goes down, the baby's heart rate goes down. Okay, and we would always have, when you're laboring a patient, you always have oxygen available. So we would want to, if that maternal blood pressure dropped, we would want to maximize the oxygen in mom's system. So even though the baby's heart rate is low, we have a higher concentration of oxygen going to the baby. So at least we can do that for the baby. Okay, so take a break a little bit. This is where we would normally have the break. And now we're going to talk about monitoring. And I obviously cannot have all of my little fun monitoring tools, but we're going to frequently check that fetal heart rate. And we're going to be looking at the pattern. Fetuses will respond to a decrease in oxygen by having their heart rate decrease. If there are a lot of heart rate decreases during contractions, during labor, if it's prolonged especially, it's very stressful for that fetus, okay? So we see these different types of decreases in oxygen supply, and all of you now hopefully have done your OB packet, so you know when we talk about the labor part, there's different reasons for decreased oxygen supply, and that's where we see different decelerations in the fetal heart rate. Okay, so a reduction of blood flow through the maternal vessels is a reason why we have decreased oxygen, and that would be like high blood pressure, like mom has high blood pressure, something that is vasoconstricting, or remember cocaine is another thing. Anything that vasoconstricts those blood vessels decreases the oxygen to the baby. Then if there's a reduction in the oxygen content in the maternal blood. So when does this happen? Probably most often during a hemorrhage. If you do not have enough of those red blood cells, you're not carrying enough oxygen. Okay? If there's an alteration in the fetal circulation, so what we look at in that case would be like compression of the cord. Sometimes babies actually squeeze their cords, or the cord gets kind of caught in between the baby and the wall of the uterus, and during contractions, or even not, when we're not having contractions, the cord can get compressed. There's also head compression that we will see if the, like when mom's pushing during the contraction, if the head is getting a lot of pressure on it, the heart rate might go down. And then obviously if there's a placental abruption, the baby's not getting a blood supply. Their circulation basically stops. And then a reduction of the blood flow to the intravillous space in the placenta. And basically what that means is that you're probably having contractions that are too hard, they're too close together, the uterus is not relaxing and filling up again with blood. So it's really stressful for the baby. Okay, so we look at uterine activity, and you can look at table 18-1 for complete detail. All right, so we look at uterine activity and fetal heart rate activity at the same time, and we kind of check one with the other. So our uterine activity, it gives us information on the contractions. Fetal compromise then is obviously how the baby's oxygenating and doing. So when we look at that heart rate monitor, just like with an NST, a positive NST, we have a nice reassuring pattern. And if we see a lot of decelerations in the heart rate pattern, that's a non-reassuring pattern. So when you have non-reassuring pattern, you have fetal compromise. So fetal compromise equals hypoxemia. If the hypoxemia is uncontrolled, you get hypoxia. Hypoxia causes metabolic acidosis. And once the fetus is in metabolic acidosis, it's called fetal asphyxia. Once you get to fetal asphyxia, the baby is dying. Okay? So you can rewind that and play that back as much as you want. But that's what we're looking for. We want to catch that fetal compromise and correct it before going further. All right. So different ways to monitor. One of the things we can do is to do intermittent auscultation. This does not happen very often, okay? Before we had Bluetooth monitors, this provided more freedom for moms. If they wanted a more kind of natural birth, we would just listen to them for, check the fetal heart rate for like 10 minutes through some contractions out of every hour, and then they could be off the monitor again. So that's intermittent, meaning we just do it here and there. And then as labor progressed, we would be checking that fetal heart rate more often. And some women still choose this for birth plans because they don't want the belts on them. But if we see any problems, we would definitely be putting them on continuous fetal monitoring, which is EFM, external fetal monitoring. FHR is fetal heart rate. So intermittent auscultation, we're probably just going to use like a little Doppler and listen to those fetal heart sounds. Or we can use a monitor and just not put the belts on. You can see the procedure on box 18-2, page 413. we're going to be checking and assessing contractions when we do this because we want to listen to the baby's heart rate before, during, and after a contraction. So we would palpate the contraction. You use your fingertips on the fundus to palpate the contraction. And it would be, a contraction is mild, moderate, and strong, depending upon how indentable that fundus is. So, some of the problems that we have: difficult to perform on women who are obese, and you don't have a permanent record. I can pull up strips that were from babies I took care of 21 years ago, because that's how long they keep them. Well, they keep them forever, but that's how long that parents can go back and sue you if there was not a good outcome. They have 21 years, which is one of the reasons why labor and delivery is such a high-risk area. So you have to also know that what mom's pulse is, so you can differentiate the fetus's pulse from the mom's pulse. And obviously, the fetus's pulse is going to be much faster, right? So even if we're doing intermittent auscultation and we're just listening every once in a while, there are standards that we have to follow about how long and how often. The other thing that we have with intermittent auscultation, you can't see a pattern. And one of the things that we can do is read a fetal monitor strip that gives us a pattern. So if you do see a deceleration, it will, you hear a deceleration, it may be a one-off, whereas if you're hearing a deceleration with each contraction, you know that there could be some fetal hypoxia. So electronic fetal monitoring is what we do the most of. And as was on the test question that I threw out, we monitor everyone. Any time someone who is greater than 30 weeks comes up to the unit, we will have a record of their fetal heart rate. We put them on the external fetal monitor and get at least a 20-minute strip. Okay, so women with problems will have it, even if they're not in labor. We still put them on a monitor. So external fetal monitoring is with an ultrasound transducer, and that's for the baby's heart rate. It's going to be that ultrasound transducer. If the baby is head down, it will be in one of the lower 2 quadrants of the abdomen. And then the TOCO transducer, and we'll see these later, but it has a little button on it. And that TOCO transducer sits right on the top of mom's fundus. And so it's pressure sensitive, and it will measure how often those contractions come, how long they last, and if the uterus rests, goes back to its a nice resting tone, it loosens up all the way and relaxes all the way so it can fill up with blood again. So the Monica one is that wireless Bluetooth one that you can, they can walk around and still be monitored. So those are the different ways that we do this. And here's a picture. You can see this is the TOCO transducer. The TOCO monitors contractions. It cannot tell us how strong they are, how much pressure there actually is. For that, we have an internal monitoring device. And then here is the ultrasound transducer. We want to figure out where the baby's back is, closest to the baby's head. And that's where we put it. And usually that's where you can hear it more often. Now, I have one of these in my office. I think you guys have seen it before. It's just a Doppler. They're both Dopplers. This one just has a speaker. And then this is a fetoscope, and you guys saw the crazy fetoscope that I wore. It basically, the fetoscope works in a different way because it's bone conduction. That's why you have to put it on your head. and somebody's forehead would go here because that will amplify the sound. So a fetoscope is weird, but it's effective. And you really want to always use 2 different ways of hearing the fetal heart tone so that you know that you're getting the baby's heart rate and not mom's. Okay. Let's see. Okay. And then here's mom on the fetal monitor, and here's the toco monitoring the contractions, and here's the ultrasound transducer monitoring the heart rate. Now, when mom gets up, usually we do 20 minutes per hour. Get a piece of strip, monitor mom, and then if she's in active labor, early labor, we'll probably let her walk around as long as she's comfortable with that, or when she's in the bath. But you can use intermittent monitoring with the Doppler when she's in the bath. Okay? All right. Okay. So we also have internal monitoring, and again, I'll show you these. The spiral electrode, it has a little wire that actually screws into the baby's scalp. And that way we can actually hear the baby's heart rate directly. It's a direct line. We're not using ultrasound then. So we know exactly what's going on with the baby's heart rate. And then an intrauterine pressure catheter is a small tube that gets inserted internally. So mom's bag of waters has to be ruptured. And we just kind of thread it along the baby. It stays next to the baby, and it will measure how strong the contractions actually are. And they're measured in millimeters of mercury. And so that you get an exact internal pressure. Okay. And there's a picture, 18-5 on page 416. Okay. And an internal uterine pressure catheter is the only way to know how strong the contractions actually are. And then here's a picture of the wireless, beltless. And it's electronic impulses, and yeah, it's basically considered portable telemetry, and it works kind of in that same way. Okay, so we're going to talk about reading strips. You need to just know some basics. We don't get terribly crazily into this, but so if we're looking at the fetal heart rate, and we're just going to look at that, we don't have any contractions on these strips. We want to get a baseline, and the baseline fetal heart rate is the average rate during a 10-minute segment that includes everything. So we measure during 10-minute segments, and this is each one of these darker lines here, between here, that is a minute, okay? Each square is 10 seconds. So we monitor for 10 minutes. That is considered like a cycle for the babies. So you only need 10 minutes, but you need at least 10 minutes. So, and let's see. So if we could see this really closely, because we can't see it very well here, this is 150, and I believe this is 180. And so if you measure across, and you could put a paper across, you could say that this baseline is probably around 170, I would say. Okay, and so we're looking for some changes in this. So periodic change or episodic changes would be any kind of accelerations or decelerations. And right here, decelerations are drops in the heart rate. So right here, this is a deceleration. So that is a change. And then also we're looking at the variability. So variability is basically what you want is for that baby's heart rate, and you can see here this has nice variability. The baby's heart rate, besides having these periodic changes of nice accelerations going on or seeing decelerations, we also want the baby to be adjusting beat to beat to its environment. So its heart rate doesn't ever stay straight like this. It's not supposed to stay straight. It should be up and down, moving around like this. The up and down moving around is called variability. Variability. Variability is the first thing that we really look at in a strip. If you have a strip like this that is smooth, I would say you could skate on that strip. There's no variability here. Okay, we would call that absent variability. There's no range. Usually there's a range in the heart rate. Remember how I said in labor and delivery we're not ever definite. We always give just a range of things. So in this, there's really not a range. It's really pretty straight. It doesn't really go up and down except for these decelerations. So A is a bad strip. It has absent variability. Okay. B, it's a little bumpier, but it still doesn't have any accelerations, because remember, what's an acceleration? It goes up by 15 beats per minute and it lasts at least 15 seconds. So, and each one of these little squares is 10 seconds. So that's how we count that. All right. Periods of this is a normal variability. I would say this is minimal and this is moderate variability, but this is the kind of variability that we look like to see. Every couple of seconds, the heart rate's moving around because the fetus is constantly adjusting to its environment. So if we have a minimal variability like on B, we have less than 5 beats per minute of difference. Okay, this strip is ominous. Okay, this is bad because it's so smooth and there are a couple of little decelerations. We don't see contractions, so we can't compare, but this is bad. All right, this could be not great, or it could be that the baby is in a sleep cycle. Okay, or we could have just given mom some IV pain medication, and that kind of quiets the baby down, so we have less variability. So this should not last more than 30 minutes. If it does, we have a problem. This is a nice, healthy baby. We're getting accelerations. There's some nice ones there. Now, it's bumpier, so it's harder to measure the baseline. But remember, we are going by a range, right? So it's really hard for me to tell. I'm going to say it's 40s to 50s baseline. And there's an acceleration that would fit. This is an acceleration. So it's a reactive strip, like just with our NST, but it has moderate variability, which we really like to see. D then is called marked variability. Marked variability. It's too much. There's greater than 25 beats per minute amplitude, so it's going up really high, and it's changing constantly, really, really fast, going up high and then down low. And that we don't really know about how much information we have on this totally. with marked variability. We'll talk about that in just a sec. So this is absent, this is minimal, this is moderate, and D is marked variability. Okay. All right. So that was our baseline fetal heart rate, is what the average is, like 140s to 150s, 145 to 150, okay? The variability are those irregular waves that we see, okay? And then these are the 4 possible categories of variability. Now, it takes a lot of time to learn how to read strips, okay? I just want you to know the very basics. So, if we have absence variability, we worry about what? Hypoxemia, right? Minimal, again, could be a sleep cycle, could be pain drugs. Moderate, normal, and then marked. Most nurses will tell you that if they see marked variability, it makes them nervous. They're worried that there's something bad going on. It could be a stress state, but there really isn't any definite evidence that it's a bad thing. But nurses will probably tell you that it is. This is called a sinusoidal pattern. It's very smooth, and it goes up and down. There's no real beat to beat variability. Normally we would want to see it squiggling. It's pretty smooth, right? And it just kind of goes up and down, and it's ASOs that we like. But we do need to see that beat to beat variability too, okay, besides the ASOs. So we call this a sinusoidal pattern. It actually is a really bad pattern. We'll see this with severe fetal anemia or fetal sepsis. Okay, sometimes if you give a narcotic, you will see it will look like this, but we know that it's not a true sinusoidal pattern. So it's called, get this, pseudo-sinusoidal fetal heart rate pattern. Okay, so, all right, so tachycardia, and you need to know these for sure. Tachycardia is, because we know that the normal fetal heart rate range is 110 to 160, right? So if we have 160, greater than 160 beats per minute, lasting the 10 minutes that we need to get, a cycle of strip, that is tachycardia. What could that mean? It can be an early sign of fetal hypoxemia. Usually when you see tachycardia, you want to check mom's temp. There could be an infection going on. It could be because of drugs, like cocaine, anything that really hypes you up. If it's fast, and especially if you see no variability, then we worry about the fetal hypoxemia for sure. Let's see. And then bradycardia. Bradycardia is less than that 110 beats per minute. Okay. True bradycardia is really uncommon. We see this. We see times of bradycardia, drops in the fetal heart rate, but if it's bradycardia, like the baseline is under 110 beats per minute, we look at, it's not really then, we don't think about fetal oxygenation in terms of that. The true bradycardia is probably caused by a cardiac problem, like the baby or the fetus is in heart failure, or some kinds of infections, or really low blood glucose, hypothermia. But if there are periods of bradycardia, if there's also variability with it, and there's just periods of bradycardia, it's not a bradycardic baseline, then it's more of an oxygenation deal. Okay. So changes in the fetal heart rate. Periodic changes are ones that occur with uterine contractions. So occur with contractions. Episodic are not associated with contractions. All right. And you guys know that accelerations are an indication of fetal well-being. So, okay, here is an example of fetal bradycardia. It's not that the heart rate dropped, it's just sitting there at 100. So, and I've seen it before with babies who've had heart problems, and it'll be like 90, which is really low. But you can see there's no variability. That 100 is the baseline. That's just what it is, right? This is conversely a beautiful strip. You have great variation here, so that's the variability, beat to beat variability. And then you also have accelerations. Look at this one, my goodness, it's 10, 25, and it's lasting 10, 20, probably 30 seconds. So that's a beautiful strip. Now we can't see any contractions down here. This looks like maybe mom was rolling over or something. So we don't have any periodic changes because we don't have any contractions. Okay. So remember, to be a good acceleration, it has to go up by 15 beats per minute and last 15 seconds. So it has to be 15 by 15. It needs to go up 15 and last for 15. So that is an important thing to remember also. We will talk about that quite a bit. All right, so you guys know that accelerations are good. Okay, accelerations are good. They're a sign of fetal health, well-being. Okay, so decelerations are drops in the fetal heart rate that are associated with different things. Okay, and it's the decelerations that you really have to know about. Okay. And the first one is early deceleration. Early deceleration, the explanation is in box 18-4 on page 421. That's for more information. But an early deceleration mirrors the contraction. So it starts with the beginning of the contraction. The heart rate starts going down, and the heart rate recovers, goes back to baseline by the end of a contraction. And usually the shape looks just like the shape of the contraction. Okay, so that's an early deceleration. We see early decelerations in response to fetal head compression. So, and when we see this, obviously, when the head is being compressed, obviously it's because of a contraction. When we start seeing early decelerations, we will check the patient because it might be time, because there's so much pressure on the head that it might be time for mom to push. So early decelerations are not necessarily a bad thing. Okay, usually the intervention would be, there would be no intervention, or the intervention would be to check the patient because she might be ready to push. All right. Late decelerations then are due to uteroplacental insufficiency. So something's going on with the placenta. And try to think about, our perfusion. So something is decreasing the perfusion from the placenta to the baby. And the explanation, a further explanation of this is box 18-5 on page 422. So what are some things that cause uteroplacental insufficiency? So some of the things that we've learned about would be what? Maternal high blood pressure, preeclampsia, anything that makes the placenta not perfuse as well. Okay? Late decelerations are a sign of fetal stress. Okay? And a late deceleration will start after the contraction starts. Okay? And the nadir, so the lowest part of the deceleration, is after the peak of the contraction. All right. And the return to baseline doesn't come until after the contraction is over with. So, and we'll look at a picture of that, and so you'll be able to see it more clearly. Variable decelerations then are due to umbilical cord compression. Like I said, sometimes the baby will squeeze the cord until they get dizzy, and then they'll let go and the heart rate will go up again. So these variable decelerations are usually V-shaped. They're kind of pointed. They might be W-shaped, but usually it's a V-shape. It's got a rapid descent and recovery. Usually they're not a big deal unless you're having really deep variable decelerations quite often. And you can see more on that. Box 18-6, page 423 is a good explanation. And again, it's just more of a quick, and they don't necessarily happen with contractions. They can happen anywhere. Okay? All right, let's look at some examples. All right, so this is an early deceleration. And you notice that the heart rate starts going down at the same time that the contraction goes up. The peak of the contraction and the lowest part of the decel, or the nadir, are right at the same time, okay? And then the heart rate starts going up as the contraction's going down. So early decelerations are usually more of a U shape, and they mirror the contraction and their head compression. Same one with this. If I draw a line, it's going to go right through here, right through the middle. It starts at the same time the contraction starts, and it ends by the time the contraction ends. So that is early. Early is head compression. There's usually no intervention but checking the patient. Late decelerations then, here's our contraction, right? Nice contraction. The heart rate doesn't start going down until after the peak of the contraction. Okay, so baby's heart rate hangs on really well until the contraction compromises that perfusion, and then the heart rate goes down. And the lowest part of the heart rate comes after the contraction is over with. Okay, it goes back up to baseline. All right, and one of these is no big deal. It would make me suspicious. But if there are many of these in a row, we're looking at fetal hypoxemia. Okay, same thing. Here's the peak of the contraction. This starts after that, and it doesn't end until after the contraction is over with. Okay, so late deceleration, uteral placental insufficiency, and so that means that the placenta is not perfusing the baby well enough. And this is a pattern that we would worry about. What else do we notice? There's minimal variability here. We don't have a lot of beat-to-beat variation at all. So that's not good, right? Okay, variable decelerations, what do we have here? These, again, they mirror the contraction. It's kind of a V shape or a W shape. Um, so there's some compression there, probably of the cord during the contraction. It's maybe being squeezed, where the maybe squeezed between the uterine wall and the baby because it's during a contraction. But again, you can see these V-shaped variable decelerations without contractions too. And they mean there's some cord compression there. And as long as they return to baseline, you're pretty okay unless you're having a lot of them and they're lasting a long time and going really low. Again, I would say that this is pretty minimal variability. And that is a variable deceleration. Okay? All right. Something that you might notice here, just there's a little tiny acceleration here, right here, and we call that a shoulder. And this makes us a little nervous because it looks like the baby is trying to compensate before that heart rate goes down. And that means that the baby may be compromised with that. So that is variable decelerations. And this is actually a real-time strip on a mobile phone. In the olden days, if we were worried about a strip, we would have to call the doctor in, and the doctor would have to look at the strip and, interpret it and get mad if they didn't think it was anything. It's kind of crazy. And now, our strips are on computers. We have central monitoring, so we can see the strips at the desk. And then doctors can actually pull it up in real time on their phones. So that's pretty darn sweet from the olden days. Okay, so again, this is head compression. What would we do with head compression? We would do a vaginal exam. And then this is obviously fetal tachycardia. If we look at the baseline, it's pretty darn straight, around 170, and the beat-to-beat variability is not there, right? Okay, and it's above 160. So that's fetal tachycardia. If I start seeing fetal tachycardia, what would I think about first? Probably maternal fever is going to be the first thing. Nurses are responsible for reading, interpreting, and doing the interventions of the fetal heart monitoring. Okay? So we have to be reading that strip in the first stage, and second stage, we have to be reading that strip every 5 to 30 minutes, depending upon the stage and the risk level of mom. So, okay. All right. We're going to keep going here. So, now, we have a 3-tiered system to easily communicate to other healthcare workers about a strip. So it's pretty darn easy. Category 1 is normal. Category 2 is not normal, but it's not abnormal. It's kind of in the middle. We're going to watch it closely, kind of like green light, yellow light, red light. Category 3 is abnormal. We have fetal monitoring standards put forth from us, and you guys are getting, 45 minutes of fetal heart monitoring, and it's like a lifetime of learning. But the categories are outlined in box 18-1 on page 411. And then we have to do intervention. If we see an abnormal pattern, we have to intervene immediately. And these are just more descriptions. So this is exactly what a category 1 is. But I can tell you, it's in that normal range of baseline, and we have moderate variability. We don't have decelerations, except for maybe early, but we want to have accelerations. Okay, category 2, it's bradycardia, but there's baseline variability, or tachycardia. So it's something that falls out of the normal, but it's not, it's just something we have to maybe investigate and watch. Minimal or absence of baseline variability, but not with decelerations. Or there's marked baseline variability. Remember, we said we don't know, we don't have proof that it's a bad thing, but most nurses would tell you that they're uncomfortable with it. No accelerations, even when we stimulate the fetus. Now, we stimulate the fetus with vibroacoustic stimulation. We'll put like a razor, a little buzzer thing on their, next to their heads on the on mom's skin, and stimulate, or we may do a vaginal exam and rub the baby's head. If the baby's heart rate doesn't go up in response to that, that's concerning. Okay, and then we will see decelerations. Okay, and then the category 3 is bad. So you have non-reassuring patterns, you have hypoxemia, and you guys know what that is, but the absence of baseline variability, so it's smooth, you can skate on it. Recurrent or late decelerations, and late decelerations are the bad ones. Bradycardia, or a true sinusoidal pattern we would worry about. Okay. And remember, when we don't have variability, we know that the fetus is not adjusting to their, or no response to the, to stimulation. We know that the fetus is not adjusting to its environment, and that's bad. We also may see prolonged decels, and I think I missed talking about that over here. Was back on this slide. Prolonged decelerations are decelerations that last longer than 2 minutes. 2 minutes or longer. So they are what they say they are, right? Okay. So management of abnormal patterns. We want to look at the 5 components that we look at so that we can evaluate consistently. Okay, so we always look at the baseline first. Is it in that 110 to 160? We look at the baseline variability. So is the baby constantly, do we have a kind of a zigzaggy, rough looking line? It's not just a straight, smooth line. We see that the baby is constantly adjusting to its environment. We check for accelerations. We check for decelerations. And then trends over time. So you can have one late deceleration, but if it's all alone and everything else looks good, we don't have to worry, right? But if the trend is that we're having a late deceleration with every contraction, that's not good. We need to do something about it. So to fix it, any corrective measure, they're all the same. We do intrauterine resuscitation. And I like POUF, P-O-U-F. So P is positioning in the lateral position, the left lateral. We already know that takes pressure off the inferior vena cava and really maximizes the maximizes the blood flow and the perfusion. Put on, and that's the first thing that you do. So position is P, O is oxygen, and I'm not talking about 3 liters here. We turn our oxygen up to 10 liters. They have a non-rebreather mask, so we have a good concentration there, okay? Now, why do you do the position before you do the O2? It's kind of like CPR. You have to perfuse. That's the important thing. You can be throwing oxygen, but if the blood isn't getting to where it's supposed to be, so we maximize perfusion. We might also, besides the left lateral, that's the most common, but depending upon what's going on, we may put the patient in Trendelenburg or have them go in a knee chest position. So, and then the U is uterus. If we have Pitocin running, we will we'll turn it off, and we can give something called a tocolytic, something that will stop the contractions and relax the uterus. We can give a medication for that. So position, oxygen, uterus, and then the F is fluids. We increase intravenous fluids to try to help increase that perfusion, keep mom's blood pressure up. So it's those 4 things. That is intrauterine resuscitation. That is going to be an important thing to remember. Okay? So other methods that we look at, the fetal scalp stimulation is when we do a vaginal exam and rub the baby's scalp. Vibroacoustic stimulation is when we take that buzzer, put it on mom's belly near the baby's head, and kind of scare them a little bit and hope that the heart rate goes up. We can get, so we get umbilical cord blood gases. We can get cord gases after delivery. We clamp off a section of the cord and take both arterial and venous samples. Okay, and there also is fetal scalp blood sampling, where we wipe off a piece of the scalp and get a little tiny blood sample. It's almost like getting a blood glucose and putting it into a machine, and it tells us how well the baby's is oxygenated, but it's seldom used anymore, and yeah, because it was cumbersome and not accurate. Tocolytic therapy. Tocolytics are drugs that we use to relax the uterus, okay? So terbutaline or breathine is a tocolytic. We use it to stop contractions in preterm labor. We would also do that if the baby was having like really bad decelerations and the uterus wasn't relaxing. Another thing that we can do is an amnio infusion. Now, and I'll show you the picture right here. This is a picture of an intrauterine pressure catheter. Remember, we're measuring exactly how strong the contractions are with this. And it's just the tube that goes right up next to the baby. But it has like a little hollow port to it that we can actually run fluids into, okay, and kind of flush things out. So if there's some bad cord compression, if the umbilical cord is stuck, because the water's broken and there's not enough in there and it's smushed somewhere, if we put fluid in, it might kind of loosen things up and relieve that cord compression. Or if the baby has had a stool in its bag of waters and we have thick meconium, we can go ahead and flush this out. The problem with that is that if you put too much in, you can overextend the uterus, and that is not a good thing. So we do have to be careful, and nurses can put these in, I guess charge nurses, and then otherwise the providers will put this in. But so those are some things that we need to remember with fetal monitoring. For the heart monitor, I'm going to move back because we really didn't talk much about contractions, and this is a good one. Now, remember we have the Toco that we put on mom's fundus to measure the contractions. And when it's that external monitoring, again, we can only monitor how often they come, so frequency, how long they last, duration, how high they go. But how high they go doesn't say how strong it is. Okay? So when we're looking and we're gonna count to see how close the contractions are together, you start at the beginning of the contraction, you count to the beginning of the next contraction, and that is frequency. So each one of these is 10 seconds. So it's starting right kind of in the middle here. So we would say that's half a minute. So 1.5, 2.5, 3.5, and another half is 4. So these would be 4 minutes apart. Okay. Now for duration, we're going to go here at the bottom and we're going to say 10, 20, 30, 40, 50, 60, 70, 80, 90, 100. Okay, so that one's a long one. That's lasting 1.5 minutes. 1, 2, 3, 4, 5, 6, 7, 8. So those are nice contractions. Okay, so again, we don't get out any calipers here. Okay, we're going to say to the doctor, yeah, the contractions are coming about every 3.5 to 4 minutes. They last 1.5 minutes. Okay, or 1 minute to 1.5 minutes, because they're all different. Okay, so when we're doing this and we have external fetal monitoring, we can see how often they come and how long they last, frequency and duration. We cannot say exactly how hard they are. We can palpate the top of the uterus, the fundus, with our fingertips during a contraction, and we can say if it's strong, moderate, or mild, but we don't know exactly how strong it is. Okay? If we have that IUPC in, we will be able to say, yes, if that's what these numbers are for, it's 50 milligrams of mercury strong. Okay, that's the pressure that's going on. So, okay. Question. While evaluating an external monitor tracing of a woman in active labor whose labor is being induced, the nurse notes that the fetal heart rate begins to decelerate at the onset of several contractions and returns to the baseline before each contraction ends. The nurse should do what? Change the woman's position. D, discontinue the oxytocin infusion. C, insert an internal monitor. D, document the finding in the client's record. So what kind of a decel is that? It starts at the beginning of the contraction and returns to baseline before the contraction ends. That would be early. So the answer would be D, document the finding in the client's chart and be watching for signs of Ferguson's reflex, which would be urge to push, right? Okay, so for those of you who are just starting OB, we will be, again, reviewing some of this in Skills Lab. Everybody else who's had OB has had more information on this. But obviously, next class, I'll answer any questions. So, have a good one. Happy snow day.